Good afternoon. So I am giving my renal grand rounds on the topic of transplantation of kidneys from HCV-Viremic donors to HCV-Uninfected recipients, contemporary practice and outcomes. At the conclusion of the activity, the participants are expected to explain the benefit of risk of kidneys from HCV-Viremic donors to HCV-Uninfected recipients, have a discussion of practice and outcomes of kidney transplantation prior of HCV kidneys prior to and after the introduction of what we call the direct acting antiviral agents, and explain the impact of transplantation of kidneys from HCV-Viremic donors to uninfected recipients based on some QI data from our local transplant center experience. As additional disclosure, the presentation will include results from studies of unlabeled indications for certain medications, primarily the DAA anti-HCV medications. And this discussion will not include detailed pharmacology of direct-acting antiviral medication against hepatitis C. In the publication of Clinical Infectious Diseases 2003, they quoted the NHANES data from January 2017 to March 2020 that the US population has 4.1 million people with HCV-positive antibody and 2.4 million with active HCV infection, meaning they have HCV RNA. And unfortunately, 50% of infected persons are unaware that they have HCV infection. The benefits of HCV screening, care and treatment is obvious. It reduces the risk of decompensated cirrhosis, hepatocellular carcinoma, mortality, and of course, it breaks the transmission by early treatment and clearance from the carriers. HCV can be transmitted through various ways, including injection drug use, healthcare exposure, which is most of interest to us as nephrologists, is in long-term dialysis, where the HCV prevalence is around between 6.9 to 8%, and other factors are shown in this slide. The natural history of HCV infection is characterized by after exposure and acute phase of resolution in 15% with chronicity in 85%. And among those 85%, 20% will go on to have cirrhosis, some with slowly progressive course. Unfortunately, 25% of them, or 4% of the total, will progress to hepatocellular carcinoma, need for liver transplant, or death. Now, this is a busy slide, but I place on inside a box for historical perspective that before the DAA era, or the introduction of the DAA antivirals, HCV antivirals, the mode of therapy for treatment has been basically interferon monotherapy, which is given subcutaneously, and it's given for a long period of around 24 weeks or 48 weeks, and has a lot of adverse side effects. That's why it's a high discontinuation rate. And the ribavirin was not recommended in patients receiving dialysis. So interferon has low efficacy and poor tolerability. It is the least effective agent in treating the most frequent genotype in the United States, which is genotype 1. And importantly, post-transplant, it has been associated with activation of the immune system, with allograft loss and acute rejection. Therefore, in the era prior to DAA, it is only recommended in cases of life-threatening liver injury or the development of fibrosing cholestatic hepatitis. Now, this is an old study that shows in the dialysis outcomes and practice pattern study. Basically, it's just saying that in this international prospective study, the prevalence of hepatitis C positive antibody, not nuclear antigen test, was 7.5%, and both all-cause mortality, all-cause hospitalization, as well as both hepatic-related mortality and related hospitalization was higher in these patients with positive hepatitis B serology. Again, the data is showing that in the Kaplan-Meier curve, those patients with positive anti-hepatitis C virus tests in long-term hemodialysis has lower survival. During a course of follow-up of 8 years, it's around 32% versus 52% without HCV antibody. Our own study from the center, we're not claiming that we are the only one who showed this, but we have associated also hepatitis C positivity after transplant to new onset diabetes after transplantation. So among the viruses, CMV has been associated and hepatitis C. And in our analysis of over 97,000 patients, the risk is over the follow-up period of 5 years, I believe, is a hazard ratio of 1.5. Now, there is a theoretical explanation for the association of hepatitis C to diabetes and insulin resistance. And this insulin resistance mechanism is present both at the peripheral tissues, the muscle and adipose tissue, wherein there is hindrance of glucose disposal and glucose oxidation. And there's also a hepatic mechanism where is steatosis, intrahepatic lipid oxidation, endogenous production, and the mediation by inflammatory or expression of inflammatory cytokines and reactive oxygen species. Now, in a meta-analysis of 18 observational studies with over 133,000 patients, again, the association of positive hepatitis antibody with all-cause mortality is what on graft loss was shown in a journal study in the Journal of Viral Hepatology. Again, in kidney transplantation, hepatitis C has been associated with a histologic finding that we call transplant glomerulopathy. Usually, when we mention transplant glomerulopathy in the setting of transplant, the first diagnosis that comes to mind is sequela of chronic rejection, namely antibody-mediated rejection with double contouring of the glomerular basement membrane. But in this study, they look at pathologic findings of transplant glomerulopathy, and they classify them as transplant glomerulopathy associated with positive hepatitis C versus transplant glomerulopathy that's negative for hepatitis C. And as you can see from the Kaplan-Meier curve, from time of transplant to graft loss, those patients with pathologic finding of transplant glomerulopathy and has positive hepatitis C has a shorter survival. Their time from transplant to total graft loss is around 6 years, whereas those with hepatitis C negative transplant glomerulopathy, their time from transplant to graft loss was 12 years. So there is an accelerated loss of kidney function in these patients. Both of them have proteinuria, 2.6 and 2.3 grams respectively. Both of them have increased creatinine. So really the most telling difference is the difference in the survival of the transplant. Now, in an old study by Pereira, who is one of the proponents of hepatitis C or hepatitis in nephrology in the 90s, they published a paper in New England Journal of Medicine wherein they look at 716 organ donors, a mixture of kidney, heart, and liver donors, and overall, they found that out of 716, 13 were positive for, this is not a NAT, this is just an antibody, 1.8% were positive. And retrospectively, they look at the course, and 48% of those patients developed what they call then as a non-A, non-B hepatitis. Remember, that was in the early 90s. And among those who had what they call as non-A, non-B hepatitis, in the period of 4 months, 12 patients developed chronic liver disease, 2 went into pulmonary liver disease. And again, 12 out of those 14 so-called non-A, non-B hepatitis turned out to be hepatitis C RNA positive. So based on these small numbers, they extrapolated that the for an anti-HCV positive donor, the likelihood of turning into an HCV positive infected recipient is around 92%. Now, the U.S. Public Health Service has updated its guideline from 2013 to 2020 regarding the assessment of solid organ donors and monitoring of transplant recipients for these viruses, namely HIV, hepatitis B, and hepatitis C. Now, these recommendations are to be used by organ procurement organizations and transplant program to apply only for solid organ donors. So this will not be used in blood products, tissues, cornea, or say other non-solid organ transplants. And these pertain to transplantation of solid organs procured from donors without laboratory evidence of HIV, hepatitis B, or hepatitis C infection. So according to this updated guideline, all living and deceased solid organ donors are, or potential organ donors are to be tested for HIV, hepatitis B, hepatitis C using both serology testing, meaning establishing the presence of antibody, in addition to nucleic acid tests for all 3 viruses. And this is regardless of the history or the risk criteria present or not present in the potential organ donor. Now, if this is a potential living donor, before transplantation surgery, this testing should occur at least within 28 days prior. Now, for deceased donors, the donor specimen should be collected within 96 hours before organ procurement, so that the intention is for the results of the testing to be available to the transplant center, the surgeon, so that they can counsel the patient appropriately regarding the infectious status as regards these 3 viruses to the intended recipient. Now, at 4 weeks after transplantation, transplant center should again test universally all recipients for HIV, HBV, and HCV infection using nucleic acid tests without regard of the history or risk factors of the donors. The American Association of the Study of Liver Diseases and the Infectious Disease Society of America has come out with an update on the recommendation for the testing and management of hepatitis C virus infection. And included in the guideline is the management of unique and key populations. And they identified organ recipients as among those in the unique and key populations. So clinical trial and real-world data provide robust evidence supporting the safety and efficacy of hepatitis C virus direct-acting antiviral agent treatment in patients who have undergone solid organ transplantation. So in this study called Magellan-2, a phase 3 single-arm open-label multi-center trial, they tested the regimen, a combination of glecaglipir and pibrentasvir for 12 weeks. This is commonly called or marketed as Mayberet. In adult patients with hepatitis C virus with genotype numbers 1 through 6 without cirrhosis. Now, just for clarity, these patients are infected or diagnosed with these viruses, not because they received the transplant. They are just already infected. And this is 3 months after primary liver or kidney transplant. So there were 80 liver recipients and 20 kidney recipients. So according to the protocol, the treatment period was 12 weeks. And then the post-treatment period is 36 weeks. And they tested for the HCV virus during this post-treatment period, and they defined cure as an SBR, or sustained viral response, which is negative HCV RNA at 12 weeks post-treatment. So according to the results of this Magellan-2 trial, the all intention to treat overall group, the cure rate is 98%. It is lower in the liver intention to treat group, which is 78/80. It is 100% in the kidney intention to treat group. And they did not see most common experience adverse effects were fatigue, headache, nausea, pruritus, and diarrhea. So in majority of the patients, the adverse effect were mild, and this is very much different with what we saw on the pattern of tolerance with respect to interferon in the pre-DAA area or era. Now, another point I want to show in this Magellan-2 trial is, since these are transplant recipients, is what is the implication of the use of one of these DAA regimen with respect to post-transplant immunosuppression, the everolimus, sirolimus, tacrolimus. And the only thing that they saw is the tacrolimus level has to be decreased between baseline and 1 week in the initiation of treatment. But after that, it has been stable. All the other regimens were stable. So in other words, it was not showing any major red flags in terms of potential interaction with anti-rejection medications. Now, this is another test. Again, these are patients who did not receive infected kidneys. They are already chronically infected with genotype 1 or 4 of Hep B, and their treatment, this is a randomized phase 2 open label trial for 5 sites in Europe. So these are treatment naive or experienced kidney transplant recipients with 1 or 4 genotype with or without cirrhosis, with GFR of more than 40 ml per minute. And they were randomly assigned to either receive the PTSP for 12. So the randomization is just the duration, whether it will be for 12 weeks or 24 weeks. Again, the definition of cure or SBR is negative viral serology at 12 weeks. I mean, RNA, not serology. So out of 100 patients, 115 patients, the highlighted in pink is the finding that this is the SBR or viral response was 100% for 12 weeks and 24 weeks. So it establishes that it is sufficient to treat them for 12 weeks and you can achieve SBR. Again, there are no major side effects. There are 3 events that are not believed to be related to the medications that were considered serious, including syncope and PE. Now, how about treatment of HCV-Uninfected kidney recipients that receive organs from donors who have the virus or viremic donors? So until 2015, and this is basically the informal cut-off of the DAA era, HCV-Viremic recipients were almost exclusively transplanted into recipients with pre-existing HCV infection. So HCV-Viremic kidneys are used to be assessed as worse quality using the Kidney Donor Profile Index, or what we call KDPI. If you go into the UNOS website, the way that they derive the KDPI is a conglomeration or of component risk factor from the donor. There are 14 or sometimes 10 that they use, but that includes age and diabetes, comorbidities, and they consider in that profile HCV positive donor as, you know, one of the risk factors. So before 2015, that this actually and actually up to now we're still using the KDPI. So also, again, based on our recent publication, that true enough, between 2007 and 2015, if you can see these boxes, those that are solid boxes means that that risk factor is a predictor for graft loss, death, delayed graft function, acute rejection, and hospitalization. And you can see that the top performing predictor was the KDRI, which included the Hep C serology of the donor. Now, this is now vigorously debated in the transplant community as to the utility of including the Hep C antibody in the computation of the KDPI, KDRI, because of these new data that are coming out. So since the advent of direct-acting HCV treatment is small trials of transplanting HCV-Viremic kidneys into recipients without HCV, and then treating them have had positive results. So this is intentionally giving the infected kidney to uninfected recipients with the intention of treating them. So before this, between 2005 and 2014, out of 6,146 kidneys from deceased donors with positive Hep C antibody, 4,144 kidneys were discarded. They were thrown out. So this amounts to around 64% of kidneys from donors who are antibody positive, not even and not positive. And that was the pattern at that time. Now you can see the evolution of the utilization trends for this. The solid black line is the transplantation of a uninfected or not positive HCV to a negative recipient, whereas the line, the box that is gray is the transplantation only of the not positive to the recipient who is also positive. So you can see that practically up to 2017, the predominant practice is to only give the HCV not positive kidneys to donor recipients, to also who are already positive. Now you can see that this equalized, the pattern equalized at around the second quarter of 2018. And since then, the pattern has been reversed, so that now you are seeing more and more transplantation of not positive kidneys to even negative recipients. And they look at the outcomes, whether it's the HCV donor, the donor or the recipient is the one who has HCV or negative HCV. They compare their GFR. They did not see any material difference between them. And then as a continuation, there is a new publication in AGT earlier this year that they continued that pattern. And the pattern, as you can see from this red arrow, is that this is the increasing transplantation of not positive donor kidney to the not negative recipient. So that between the April 1, 2016 and June 30, 2022, around 4,500 of this transplant has already happened in the United States. Now, again, AJT transplantation look at the what happens to the graft survival of these patients, and in this Kaplan-Meier curve, the blue line represents the control, which is the both antibody and not negative transplantation. The one that is light green is the not positive transplantation, and the red one is the antibody positive but not negative. So basically what the graph is showing is there is no significant difference. There is crossing of the lines in terms of graft survival for these patients. And analysis by Cox models considering other risk factors or confounders had confirmed that there was no significant risk associated with the not positive transplantation. Now, this is now a study on the use of DAA on these groups of patients who are, or recipients who are negative for hepatitis C and receive hepatitis C infected kidneys. So this trial was performed to determine the safety and effectiveness of transplanting kidneys from HCV positive donors into HCV negative patients on the wait list. And then they were planning to give appropriate direct acting antiviral agent after the transplantation. This was an open-label pilot clinical trial using cifavir or glasopivir, elbasvir, and Mavorec. So these are two-part separate formulation. And these are all, of course, deceased donor transplantation. This is not being done for living donor transplant. So again, the treatment was given for 12 weeks for most subjects. So this study started, their actual study started in January 5th, 2016, and they completed the study in December of 2022, and they were able to enroll 62 patients. This is a phase 1 and phase 2 study. So phase 1 is safety, phase 2 is efficacy. So basically, again, this is a basic slide of inclusion and exclusion criteria. What we can see is these recipients are adults, 30 to 70 years by age. They have PRA of less than 17%. But an important thing that I highlighted in red is if the patient has a known history of sensitivity to tacrolimus, they were excluded because if they might need to be placed on cyclosporine, the medication cifavir is not compatible with that. So that's one caveat of this study. So again, this is a table from the clinicaltrials.gov regarding this study. So the outcomes measure is the baseline to 24 weeks for the efficacy, meaning the negativity of the HCV RNA. But for the adverse outcome, they extended the time frame of observation to 52 weeks. So there were 62 participants. The age group is in the middle age, 57 years old, between 50 to 62. And there's an almost equal African-American Caucasian patient distribution between the groups. Now, the most important outcome of this study in the clinicaltrials.gov is that 62% of the patients reach SBR, or the intended definition of cure, at 12 weeks. So that was a 100% cure rate. Now, I showed you that this study was started, 2015-16, but anyway, some part of that before this final result, they extrapolated data from 10 from the study, another 10 from the transplant patients at the University of Pennsylvania, and they came up with some analysis. And again, in that early, they were able to show that true enough, the SBR rate was 100% for 3 patients treated at 12 weeks. Now, again, in this extrapolated study from the University of Pennsylvania, they compared the GFR at 6 months and 12 months between the recipients of HCV positive and negative kidneys, and they were that were in the treatment, under treatment, and they were basically there's no difference. There was a transient self-limited LFT elevation, but no episode of acute rejection was seen. Another study on the use of direct-acting antiprophylaxis in kidney transplantation to hepatitis C virus-infected donor recipient is being shown next. Now, this is a study on the tolerability and feasibility of treatment, and the important point here is that they are giving the prophylaxis even before the actual transplant. So this is prophylaxis before and after kidney transplantation. So this is a small study. They have 10 HCV donor positive, recipient negative candidates. And this is, again, all intended to enroll older than 50-year-old patients. This one's done at Johns Hopkins University, and they included dialysis patients or CKD stage 5 who were not on dialysis. So I highlighted here that patients receive this regimen immediately before transplant. Actually, this is for deceased donors. So once the patient is called for the transplant, when they are admitted while they're waiting to go to the OR, basically hours before the transplant, they administer the medication. And then what they did is post-transplant, without waiting for any viral testing, they went ahead and continue on giving the medication for a continuous period of 12 weeks. And in this manner, they were able to show that they achieved also at 12 weeks a HCV cure, or sustained viral response. So the question is, what's the point of giving a dose before transplantation and still giving it anyway after 12 weeks? Isn't it the same as the previous study? Well, I think I'm showing this because this is where the data shows that if you can see on the column that shows HCV RNA level, IU per ml, POD1, which is post at day 1, you can see that the positive HCV-RA developed only in post of day 1 between in three patients. So the hypothesis is probably this is not even the likelihood is this patient might even be incubating, or it's from the patient, not the donor. But the point is, none of those patients who patients develop viremia after the post day 1. So their hypothesis is giving it ahead before perfusion of the kidney has somehow a preemptive effect on preventing viremia from developing, because in the previous study, the viremia can develop at the rate of around 2 to 5 days after the transplant. Now, I think this is the last study, a representative study. It's called the MYTHIC study. This is a multi-center open-label study of glycanprevir/remdesivir, which is called, again, MAVERIC. This is an interventional trial with 30 recipients that was started on April 2019 and finished in 2021. Now, this one, the point of this trial is to see if instead of 12 weeks, they can abbreviate the treatment with DAA for 8 weeks. And again, based on these small 30 participants, they were able to show that this regimen, the MAVERIC, was able to resolve the HCV viremia after transplantation in 100%, and there was no treatment failure. So basically, the schematic representation of this MYTHIC trial is the 8 weeks of once daily glycanprevir and remdesivir. And actually, it was started 2 days to 5 days post-op, and then continued on for 8 weeks. And they checked for the presence or absence of Hep C virus 12 weeks after completion of treatment, and all of them resolved the viremia. Therefore, according to the recent publication of the ASLD, HCV treatment should occur as early as possible in HCV seronegative patients who undergo transplantation with a non-liver graft from an HCV-Viremic donor, because this strategy is intended to reduce the likelihood of hepatic and extrahepatic HCV-related complications in the immediate post-transplant period. Now, the first, I think an issue about here is the ethics of this practice, because if you analyze it, it is knowingly transplanting an infected organ to an uninfected recipient. So it's you can say it's knowingly infected transplant recipients with HCV, so the rigor of the informed consent process and respect for patients' autonomy to minimize possibility of iatrogenic harm should be considered strongly. Now, one argument is transplant physicians should offer these HCV positive organs to uninfected patients who have high risk of deterioration in their health if they continue on dialysis, meaning this is balancing the risk and benefit. Who are these patients? Elderly patients or those with serious coexisting conditions such as cardiovascular disease, those with common blood types that have a long waiting time. So if they are type O or type B, or other conditions, maybe if they have high PRA, high antibody titer. So these conditions will mean that they will stay on the waiting list for a long while, but in the meantime, their health may deteriorate while on dialysis. So this is one of the consideration for potentially offering these kind of transplants. For these vulnerable patients, HCV positive donated kidneys could provide a singular opportunity to undergo transplantation. And since the studies that we have seen has shown that the survival benefit of kidney transplantations in those that can be treated with DAA, there is a reason to believe that providing these HCV positive kidneys and then treating these recipients will lead to better outcomes rather than them developing more complications waiting on dialysis. So that's very crucial to have an informed consent process, to have an explicit communication about the currently known HBQ rate and the risk of complications. And some complications that may be discussed with the patients are, of course, you cannot exclude the possibility of acute hepatitis or a rare fibrosing cholestatic HCV. And there's even literature that even people with HB core positive but considered to be HBs negative, there are some episodes of reactivation while under DAA therapy. That's why these viruses have to be rechecked before giving them the medication. Now, is there a previous precedent to this type of discussion to the patient to put this in perspective? Because again, in the 1990s, these similar concerns were raised about organs that were positive for Hep B core antibody. At that time, again, it was sort of an ethical dilemma. It's a lot of question about that. But nowadays, that is commonly transplanted with reassuring results. And that's why also the people on dialysis should be vaccinated for and has antibody titer to hepatitis B. This is one of those reasons. So they are well protected should they receive this kind of transplant. Another infection that is in effect also giving risk to an uninfected patient is CMV positive kidneys. You know, you do not question whether a kidney is CMV positive or negative. You just trust that after transplant, even if the patient is CMV negative in serology, they can be prophylaxed with Balsite, and this is common and accepted practice. So along that line, they are saying that this practice of HCV infected to uninfected transplant is ethically acceptable. So before placing the patient on the wait list, there should be this informed consent process, and this is basically part of the role of the transplant nephrologists in our transplant clinic. That's why our evaluation clinic can take an hour, not because of taking their histories and all these counseling that we have to do, and this is just one of those. And the discussion should include opportunities to address concerns related to the risk of HIV, hepatitis B, hepatitis C via organ transplantation. The transplant center should make an effort to contextualize this discussion, and the recommendation in the guideline is to include a language to the effect that the risk for undetected HIV, hepatitis B or C is very low but not zero. The risk of undetected infection is less than 1 in 1 million for HIV after 14 days, for hepatitis B after 35 days, and for hepatitis C after 7 days from the time of the most recent potential exposure of the donor who has a negative nucleic acid test. And they should also be counseled that they will be tested for HIV, HBV, and HCV after transplantation, and should transmission occur, effective therapies are available. Again, the patient can be told that their transplant, as a transplant candidate, they may, depending on their risk and their comorbidity, their age, they may have a higher chance of survival by accepting organs from donors with risk factors for HIV, Hep B, or Hep C, compared with waiting for an organ from a donor without risk factors, and the meantime, staying longer on dialysis. Now, the new guidelines, they made an simplified algorithm for instituting this treatment. I think the most important is determining whether they have cirrhosis or compensated without cirrhosis or compensated cirrhosis. So there is FibroScan and other non-invasive testing. This is basically in our center being done by the hepatology liver transplant. We have an arrangement with them that they automatically see this type of recipients. Now, again, this is a long release of the pre-transplant assessment, which will be basically self-explanatory. I want to emphasize medication reconciliation because these patients will be on an immunosuppressant medication, and the importance that the patient, the recipients, will also be, aside from being tested if they acquire the hepatitis C virus, is the genotype will be known, because there are certain genotypes that may be associated with resistance to the regimen, and those people with resistance to regimen may need to be placed on an extra additional ribavirin therapy in addition to this standard DAA, and that's why genotyping is important. Now, going to the topic of medication reconciliation or assessment for drug-drug interaction, the only caveat is cyclosporine increases the area under the curve of the regimen called elbasvir-gazoprevir, and also sofosbuvir-velpatasvir. And this sofosbuvir regimen is the one we are using. This is called Epclusa. So if patients will be placed on cyclosporine, that will be problematic for these patients. The on-treatment monitoring is, again, for patients with diabetes. They are and on medications. They are monitored for the presence of hypoglycemia, for interaction between the DAA and warfarin, resulting in subtherapeutic anticoagulation, and also clinic follow-up. And then the post-treatment assessment is after they completed the treatment, they will have verification of cure by an HCV RNA test and hepatic function at around 12 weeks after completion. So in UF Health, this is basically a rough schematic of what we do. So the pre-transplant evaluation include hepatitis serology, liver function, and all transplant candidates receive abdominal CT scan to look at their iliac vessels. And at the same time, that will help visualize, of course, the abdominal organs, including the liver. The pre-transplant education on counseling on risk benefit of receiving kidneys from donors with risk, not only from Hep C, but we also specifically mention specific counseling on the risk benefits and anticipated follow-up and treatment related to the Hep C kidney transplant. So we informed them that you will have an extra clinic visit on top of your post-transplant kidney transplant. You will have to go to hepatology for these the actual management. Now, when the kidney or offer becomes available during the phone call that is done by the transplant coordinator, they confirm if the patient is interested and willing to accept a hepatitis C organ, and they try to obtain a verbal consent to move forward with for this high-risk kidney. Because if the patient will say no, then they can just say, okay, that's fine, you're still on the list, but we will have to move on to the next on the list who might be interested in accepting this kidney. If the patient seems agreeable, they will come to the hospital, they are admitted, they have the pre-surgery labs are ordered according to the routine of the transplant program. Then the surgeon will obtain the final pre-transplant informed consent for the HCV kidney transplant to uninfected recipients. UNOS is very, very strict about this. So during our audits or when audit is coming, we all check our list of recipients and we make sure that these consents are there scanned in Epic, because we can be cited if they cannot find these consent forms. Now, kidney transplantation-wise, there is really no change in the protocol of induction or maintenance regimen. So we are not going to not use ATG or Campat because we are worried about worsening the HCV infection. We do not consider that as a really a big issue. Now, the post-transplant monitoring of HCV RNA and genotyping before discharge, this is done, and then patient will have follow-up with the hepatology clinic for the actual treatment of HCV with the DAA regimen. And that includes the post-completion verification at 12 weeks after DAA. And the definition as shown in all the studies and the guideline is the patient should obtain a negative virus at 12 weeks. Now, QI data from our transplant. So since July 21st, 2021 up to July 2nd, we have transplanted 48 Hep C positive to kidneys to negative donors. For those that we can have follow-up, I included in this QI data the July 2021 to February 2023. So at least we have 6 months follow-up. So as you can see from here, the patients, we have overall of 38 patients analyzed. So we divided them into 2 groups. We divided them into those who are able to start the antivirus treatment within 47 days of, because that's the median start date in our program. So it's kind of prolonged. And that is the issue in real life, is even if all these studies are saying you can give it preemptively before transplant, or you can give the medication at day 0, those are data from control trials. In real life, once you have to get insurance approval, and for you to get insurance approval for the medication, you have to show that they have viremia. So in reality, there is a problem of delayed initiation. So that is the question is, this is not included in the standard informed process, the informed consent. We have to say that there is a possibility that your treatment will be delayed because of issues outside of our control, like insurance. And so that's why we divided them into the short DAA lag time to the long one. So basically, there's no significant difference between the 2 groups at baseline, but you can see here that from transplant to viremia, it is 3 to 4 days, which is basically what the studies had shown. It's 2 to 4 days they develop viremia. Now, regarding the GFR at 6 months, you can see that the 2 sides are practically the same. Those who have started the antiviral at short period before or long, they have the same GFRs. We also had the same Peak RNA value, 1.2 million in the long lag time, actually short, smaller, and in the short lag time, it's 1.8 million, but they were not statistically significant. Even the time it takes to achieve a cure or SBR cure, it is only longer by 10 days in the delayed initiation group, but it's not statistically significant. Now, regarding hospitalization, it is 15% higher in the long viremia group, but this is not statistically significant. I don't know because of the smaller sample size. But when I look at the specific causes, they are really UTIs, post-surgical complications. So I don't see any red flags related to being related to HCV or the treatment itself. So in conclusion, there has been an increased utilization of HCV RNA kidneys for transplantation in the DAA era. Anti-HCV DAA appears effective and safe in small studies in HCV kidney transplant recipients who receive HCV-positive kidneys. Now, except for significant interaction of some DAA with cyclosporine, no major barrier exists for DAA use on the account of transplant immune suppressant agents. Thank you very much.